The Genuine Article. Discussion and commentary based on articles from JACC.
About 1 in 3 patients who undergoes cardiac resynchronization therapy doesn't derive a benefit, and this raises important questions about the efficacy of the pacing sites being used in this procedure. I'm Tony DeMaria, the editor of JACC, and I'm talking with Dr. David Spragg, who's Assistant Professor of Medicine at Johns Hopkins University and who has a really important study in press in JACC that deals with this topic. So, David, why don't you outline our study for us?
Sure. This was a study that was motivated by wanting to improve response rates to cardiac resynchronization therapy, and we set out to characterize the optimal site for left ventricular pacing in a small series of patients with ischemic cardiomyopathy.
Now, you did a really elegant study. You paced multiple endocardial sites, in excess of 50, as I recall, from throughout the ventricle, and compared that to epicardial pacing as well.
That's correct. We used a Millar catheter to measure peak pressure rise over time, and we performed asensed and V-paced biventricular pacing from the right ventricular apex, and as you indicated, from generally over 50 different left ventricular endocardial sites, and we were able to map out in these patients with ischemic cardiomyopathy where the best sites were.
And why don't you give us the results?
What we found was that there was a high degree of intra-patient heterogeneity in the location of these optimal left ventricular pacing sites. And so some patients might have had a best pacing site at the left posterior lateral wall or left lateral wall of the ventricle, as you might predict. But frankly, the majority of these patients did not get optimal mechanical response from that posterolateral left ventricular site. Rather, they had sweet spots that were scattered around the ventricle. We also found that there was no clear benefit from endocardial pacing when compared to epicardial pacing from a coronary sinus lead.
Now, you also looked at the important question of the pacing the site of latest activation, the mechanical desynchrony part of it.
We did. We hypothesized that regions of latest electrical activation in our study may or may not correlate with optimal sites for left ventricular pacing, and we did not find any clear correlation between those sites of latest electrical activation and optimal mechanical response for pacing. I'll point out we didn't look at sites of latest mechanical activation, so there was no, for instance, echocardiographic or magnetic resonance imaging component to our study.
So, in terms of practical questions, I guess we insert these leads in the coronary sinus and we're limited by the anatomy of the venous system. Is that something we should persist with, or should we start thinking about a surgical implantation or endocardial positioning?
Sure, that's very much the direction in which we are moving. I think you've identified one of the major limitations of CRT as it exists now. And that's that we're confined to the tributaries of the coronary sinus. And so one of our clinical efforts moving forward, and we're not alone in this, is devising systems that aren't limited to the coronary sinus anatomy and perhaps doing tailored cardiac resynchronization therapy where for a particular patient we identify the optimal site of pacing and then implant a lead there, whether or not that is using the coronary sinus anatomy or perhaps through direct LV endocardial lead implantation.
Well, I guess in terms of limitations, we would have to say that it was a relatively small number of patients. DPDT may not be the best marker of benefit of CRT. And you did require in many of these patients transeptal catheterization.
It was a very difficult study to enroll. We enrolled for 3.5 or 4 years, and over that time, as you pointed out, we enrolled a fairly small number of patients. And part of that was that this was, from our standpoint, really a mechanisms or a methods tour de force. I mean, we had double left ventricular access for these patients, and as you pointed out, we paced in 50 to 75 different sites in the left ventricle. So it is true it was a small number of patients, but we really tried to study that small group as best we could.
Well, I think these findings are really important. We've all suspected that the limitation of the coronary sinus anatomy in placing the resynchronization lead might be a major problem, and I think your data support that very much, and the potential to get much better benefits from CRT by doing mapping really is intriguing. Thanks very much for sharing this with us. For the Genuine article, I'm Tony DeMaria.